Good morning, everyone. Welcome to Yale Cardiovascular Grand Rounds. It's actually a huge honor to introduce Barry Borlaug. Barry's done some of the seminal work in understanding the pathophysiology of heart failure with preserved ejection fraction. Barry did his internal medicine training at the Brigham, followed by cardiology training at Hopkins, and he's been at Mayo Clinic since then. Barry, now that you're giving Grand Rounds to Yale, you're part of the Yale cardiology family, so I hope you wear that proudly at Mayo.
Thank you very much.
And with that, I'll let you give your Grand Rounds.
Thanks, Tarek. Thanks for having me. It's really a treat and an honor for me to see old friends and make new friends. So I'm going to talk about heart failure preserved EF, or HFpEf, and I'm going to focus a little bit more on some of the maybe forgotten victims of diastolic dysfunction. What do we mean by that? So these are my disclosures. And then I want to just very briefly, for those of you who don't think about HFpEf as much, review some of the recent epidemiology and information about diagnosis, but we'll just do that for a couple minutes and we'll really take a deeper dive into what I talk about as the victims, implications for pathophysiology and for treatment in people with HFpEf. So we all know this. Heart failure is a big problem. We've been saying it's about 6 million Americans. That's increasing up to 8 million in the next 10 or 12 years. And one of the reasons for this is the aging of our population. On the right-hand panel, the purple is the number of people in America who are 65 and above. And you can see that that is increasing very dramatically from about 45 million in 2012 up to close to 80 million by 2030. So we're getting much older, and that is partially accounting for the increased prevalence of heart failure with preserved ejection fraction. Now, we talk about the heart failure epidemic all the time, but actually the incidence of heart failure overall is reducing. And that is because this is data from Framingham and the Cardiovascular Health Study that shows that the overall incidence is decreasing, but that's related to a reduction in the incidence of HFrEf, which you can see here in the middle. When you look at HFpEf from the 90s, 4.7 cases per 1,000 patient years, up to the aughts, 50% increase. So heart failure with preserved ejection fraction is growing relative to HFrEf by at least 10% per decade. Part of that maybe is increased recognition, but we also think that there's some significant changes in secular trends here, so it's becoming a big problem. Now, we used to say, we still say, in the papers and the grants, about half of all patients have heart failure, but this is data from ERIC, which is a large community-based study, and they looked at all stages of heart failure, and stage C, so C1 is any heart failure diagnosis, C2 is people that have been hospitalized for heart failure. And you can see that as you get older, the prevalence of stage C heart failure gets much higher, but what was interesting in this study was over 70% of people with heart failure had heart failure with preserved ejection fraction in this study, 77% with C1. So it's really not just half. It's becoming much more common than half and continues to be under-recognized. I think it's really just the tip of the iceberg here that we're seeing with these people because it's underdiagnosed and underappreciated, particularly in the non-cardiology specialties. This is a typical patient I see. I think you guys probably do here. 70-year-old lady with severe symptoms of breathlessness, lifestyle limiting dyspnea, class 2, class 3. Comes to see me in my clinic for a third opinion. She's been told that she's just depressed, or she's just obese, or she's just deconditioned, but none of these answers are really satisfying her. Typical demographics, she's older, she's hypertensive, she has metabolic syndrome, but she's never been admitted with pulmonary edema. She doesn't have objective evidence on physical exam. She's quite obese, but her BNP is normal. Her jugulars look normal, there's no edema. Of course, you get an echo. And the echo EF60, and then we've got kind of this sort of intermediate stuff. Really not enough to say that she has heart failure here, but not totally normal left atrial volume or EE prime. And there's algorithms, I'm not going to go into these, but there's an algorithm from the ESC that gets used most frequently to say whether you have HFpEf or not based on non-invasive criteria, and that would say she doesn't have heart failure. So what do we do with this patient? Well, we could tell her for the fourth time that you're just obese and deconditioned and depressed, and that might be true, but it's really not a sufficient explanation. So this is the kind of patient that we would take to the table of truth. So that's what we do at Mayo, and that's what we did here. So this is at rest. This is her LV pressure in red and her wedge pressure in black. And you can see they're stone cold normal, 12 millimeters of mercury. So we've done a history, physical, BNP, echo, cath, it's all normal. But she's not symptomatic at rest. She's symptomatic when she exercises. We have to stress the system to bring out the hemodynamic abnormality, just like you would in the evaluation of patients with coronary disease. So we get her legs up on the pedals for supine ergometry and just 40 watts of exercise, which is a very low objective workload. This is what happens. Now you can see her wedge pressure and her LVDD are 40 millimeters of mercury, and she's extremely short of breath and tachypnic. So this is HFpEf, but this wasn't HFpEf until somebody did the proper test to make the evaluation, and that's why I think it's the tip of the iceberg here. But this is exercise testing, invasive hemodynamic exercise testing has really emerged as the gold standard to definitively identify or refute the presence of HFpEf, and it's extremely valuable in that regard. So to try to deal with this problem, we came up with this new score to hopefully raise awareness about HFpEf. So over the last 12 years or so, I've accumulated a lot of patients that had HFpEf or didn't have HFpEf by invasive catheterization. And we took all those patients and we looked at all of the clinical and echo and laboratory criteria, chest x-ray criteria, and found which ones were most predictive. And then we put them into a most parsimonious multivariable model, and we came up with this scoring system. So these 6 variables can tell you the likelihood that a patient that you're evaluating with a normal ejection fraction and unexplained dyspnea has heart failure with preserved ejection fraction. So obesity, hypertension with 2 or more antihypertensives, AFib. Notice that AFib is worth 3 points. That really increases the likelihood that there's HFpEf. Obesity also 2 points. pH by CAT or by echo, RVSP of 35, older age above 60, and high filling pressures by echo, EE prime above 9. That's not 15, that's just 9. You sum these up, and the beauty to me of this is that you can then estimate the probability that HFpEf is present. You can see here from this nomogram that if it's 6 to 9, it's above 90% likely that they have HFpEf. If it's 0 or 1, it's extremely unlikely. If it's intermediate, that's when we need additional testing. And I think that's the time when you do invasive exercise testing or other modalities to refine the diagnosis. So I'm hopeful that we can kind of keep this in our heads, and particularly in the general clinics, to increase awareness about the problem of heart failure with preserved ejection fraction. So that's all I'm going to talk about with diagnosis. Now we'll talk more about the fun stuff with pathophysiology. So what is the root cause of HFpEf? Where does it all start? It all starts, and we all have been talking for years about diastolic dysfunction, obviously. So there's prolonged relaxation on average, and there's an increase in chamber stiffness. This is from Zile's study over 10 years ago now. The diastolic pressure-volume relationship is shifted up and to the left, stiffer ventricle in these patients at rest. And with exercise, this stiff ventricle becomes even stiffer. You can see that the end diastolic pressure there in red goes up to 30, but the whole steepness of the relationship increases dynamically. The pressure also goes up in a parallel fashion as well, possibly mediated by pericardial restraint. So this is very clear. No one argues about this. No one quarrels with this. But what does this do? Why are high filling pressures bad? Well, we've been very interested in this. And when you look at patients, so if you look at their hemodynamics, on average, patients with HFpEf have somewhat higher filling pressures at rest, but many are normal. It's really that first workload of exercise, when you get that bolus of blood coming back from the legs, that you really see major separation between the two groups. So what then happens to pulmonary function and pulmonary mechanics with that? Well, you see a greater increase in inspiratory drive. This leads to the onset of a rapid, shallow pattern of breathing. There's a greater perception of breathlessness and tachypnea at matched workload. And the increase in wedge pressure, as you can see here, is modestly but significantly correlated with the increase in symptoms of dyspnea. So on the y-axis there are the Borlaug distance, asking them how short of breath are you, and you can see that the patients with the greater increase in filling pressures are complaining of more shortness of breath during submaximal exercise. Patients with higher exercise wedge pressure have poorer exercise capacity, and this is independent of other components of the Fick equation, cardiac output, ABO2 difference. You can see whether it's supine exercise in red or whether it's upright treadmill exercise in black, the higher your left atrial pressures with exercise, the poorer your exercise capacity. So it's associated with symptoms, altered ventilatory patterns, exercise capacity, and also mortality. So this is data from Germany from 5 years ago, and they looked at patients undergoing exercise hemodynamic evaluation, and even people with normal resting wedge pressure, if it went up during exercise, increased risk of death. So it's a really important therapeutic target, and we all know this. What happens in the lungs when the filling pressures go up? Well, we all, think about Starling forces, and we learned about this in medical school, but there's actually very little in vivo human data on what happens with this. And it's because it's very hard to quantify lung water. But we have this new technique, which is actually quite easy. Lung ultrasound. So you take your probe, and you just move away, like what you're doing when you're learning how as a cardiology fellow, that the heart's not there. It's, you get in an intercostal space, and you do sonography of the lung tissue. And normal is shown there on the far left. As you develop an increase in extravascular lung water, you start to see these laser-like projections called B-line artifacts. And the increase in the number of those B-line artifacts is indicative qualitatively of an increase in lung water. It doesn't tell you whether it's lung water from ARDS or heart failure, but if it's dynamic, if it's changing with hemodynamics, it's likely it's due to heart failure. So we recently completed a study, 51 patients with HFpEf, and they underwent the usual kind of workup that we do. Invasive, high-fidelity micromanometer catheterization, rest, exercise, expired gas analysis, simultaneous echo, but also with lung ultrasound. And this is in review right now. We saw that a little over half of the patients with high filling pressures with exercise developed these B-line artifacts with just 20 watts of exercise. We stopped at 20. We didn't go to peak. It's likely that a higher proportion would have developed some pulmonary congestion and higher workload. So what was different about these people? So the people with an increase in lung water during exercise are in red. The people without are in black. LVEf was not different. No difference whatsoever. What was different is RV function. The prevalence of RV dysfunction was almost threefold higher in people that developed lung water during exercise. This is tissue Doppler systolic velocities in the LV, and you can see that there's no difference. On the right, you can see in the RV, there's a striking difference. This is their hemodynamics. So cardiac output is on the x-axis and wedge pressure is on the y, and going from exercise, your cardiac output goes up. At any output, the wedge pressure is much higher in the people that develop lung water, but so is the right atrial pressure. In fact, the difference here, the delta, is even a little bit more striking. These are measures of RV-PA coupling. So we've got 3 different echo measures of RV shortening. So systolic velocity on the far left, the middle is TAPSE, and then the far right is fractional area change divided by RV afterload, estimated by PA pressure. And you can see that during exercise, RV-PA coupling is substantially diminished in the people that get lung water during exercise. And the people with the poorest RV-PA coupling are those people that have the greatest right atrial hypertension during exercise. So we then ask the question, what predicts the development of an increase in lung water during exercise? And as you would expect, high filling pressure, high wedge pressure during exercise, area under the curve 0.78. So this fits with the current paradigm. When you get left atrial hypertension, you get pulmonary capillary hypertension. This causes filtration of water into the interstitium, makes the lungs wet, makes sense. But right atrial hypertension was just as strong of a predictor, and so was RV dysfunction, whether it was RV dysfunction at rest or exercise, or RV-PA coupling, which actually had the highest area under the curve, 0.85. So sure, an increase in left atrial pressure increases pulmonary capillary pressure, increases water filtration, but normally that water is rapidly pulled out of the interstitial space in alveoli by what? Lymphatics. Maybe if the lymphatics aren't working from RV dysfunction, this increases or decreases clearance of water from the lungs. And this is just a reminder of these parallel circulations. So, blood goes through the lungs, drops off CO2, picks up oxygen, goes to the left heart. Left heart pressure increases because of heart failure. You get increased capillary filtration. Normally that's pulled out, but where do the lymphatics drain? They drain via the thoracic duct into the central venous circulation. If that central venous pressure is very high, maybe you've increased lymphatic afterload, and maybe that is the explanation for this very strong relationship with RV dysfunction. To me, this is really interesting because we think about RV dysfunction and those patients are usually protected from left heart failure. And we think that they can't get pulmonary congestion because their right heart can't push it through. But this data suggests that that's not the case. Now, when you look at animal models, so this is, we were talking about Guyton at dinner last night and all the things he did. So this is clamping the aorta of a bunch of dogs. And you can see that normal dogs can sustain left atrial, increases in left atrial pressure up to about 25 before their lungs get wet. After that, there's a monotonic increase. And what does that do? Excuse me. I usually like to show PV loops in the ventricle, but these are actually pulmonary PV loops. And you can see, so lung volume is on the x-axis, lung pressure is on the y-axis, and the pulmonary pressure-volume relationship shifts up and to the left. So as the lung gets wet and congested, it gets stiffer, and maybe this is also part of what's happening in people to make us short of breath with left atrial hypertension. What happens chronically with this? This is from an animal model. This is not human tissue. But on the left-hand side, you can see a normal alveolar capillary interface. It's nice and thin. The basement membrane is nice and thin, allowing for efficient gas exchange. With chronic left atrial hypertension, that's shown on the right, that alveolar capillary interface becomes very thick. The basement membrane becomes thick. The conductance is reduced. Now, the good part about this is it protects the alveoli and the interstitium from chronic left atrial hypertension. But the bad thing is it interferes with gas exchange in the lungs. And we've seen this when we've evaluated for lung diffusion properties. So this is DLCO at rest and during exercise. So maybe I will use this clicker. So these are controls, age-matched sex controls. These are patients with HFpEf. This is rest. This is 20% or 20 watts of exercise, and this is peak exercise. So for at rest and with exercise, for any cardiac output, lung diffusion is impaired. Now, what are the determinants of lung diffusion? It's related to DM, or what's called the membrane conductance. This is how fast gases can transfer through the alveolar capillary membrane. But it's also related to how much blood is in the capillaries. That's VC, that's the pulmonary capillary blood volume. You've got to have enough blood there to allow for gas exchange with erythrocytes. We see that the membrane conductance, so you can get both of these things if you simultaneously measure the diffusion capacity for carbon monoxide and nitric oxide together. So basically you get two equations, two unknowns, you can solve for both these components. Now, DM is much reduced, so that there is some evidence of alveolar thickening. And these are patients with relatively early HFpEf. These aren't these people with RV dysfunction and really severe disease. These are relatively early HFpEf. Poorer gas conductance at rest, poorer with exercise. This is the pulmonary capillary blood volume. So at rest, the HFpEf patients actually have pulmonary capillary oligemia. So they have less blood sitting around there, maybe because their RV is not pushing through, maybe because there's chronic remodeling. With early exercise, they reach up to the level of the normal controls. We think that's probably because of that left atrial hypertension, because they're filling their capillaries from forward flow from the RV, but there's also backward distension from that acute left heart failure. But then after that, there's no further increase in capillary volume because you've basically taken all the pulmonary reserve, and we think that's related to this chronic remodeling. The presence of low DLCO in people with HFpEf is one of the worst indicators for long-term survival. This is way stronger than BNP or RV dysfunction. This, at least from this one study, having a low DLCO is a really strong predictor of adverse outcomes. These patients usually have normal chest x-rays and they usually have normal CTs. So we can't see it. It's not like they have ground glass thickening or opacification. But if they do have gas exchange abnormalities, is really identifying people that have more of this alveolar problem. Now, acute lung congestion, this is classic studies from West. Acute lung congestion causes edema in the interstitium, but it also causes vascular edema. And that's shown here. This is a small pulmonary arterial vessel. And this is thickening due to congestion. This acutely increases pulmonary vascular resistance and alters the distribution of blood in the lungs. This is actually what causes sepalization on the chest X-ray. Normally, as you can see on the top here, the alveolar septa keep the vessels open, but with acute left heart failure, there's thickening of those vessels, and that causes an acute increase in pulmonary vascular resistance. You diurese the patient, you bring the pressures down with nitroprusside, and this gets much better. But chronically, what happens chronically with this? This is one of the unmet needs, really, I think. We don't have enough histopathologic data of the lungs in people with heart failure. So this is Maggie Redfield's study published in Circ last year. The top is normal controls. The middle panel, or the second panel, is patients with HFrEf. This is patients with HFpEf. And this is patients with pulmonary veno-occlusive disease. And looked at all the vessels. We saw evidence of intimal thickening in the arteries, these things called intermediate vessels, and also the veins. And that's what's shown here. And the veins were actually the most striking. Marked intimal thickening and remodeling in the pulmonary veins in patients with HFpEf. And the magnitude of intimal thickening of these vessels was correlated with, before death, measures of pulmonary vascular tone. Transpulmonary gradient is shown here. So it's not as severe as the rare thing of pulmonary veno-occlusive disease, but maybe chronically this is playing an important role in these patients. The presence of pulmonary vascular disease identifies patients at increased risk. So this is from Mark Simon and colleague at Pittsburgh. This is patients with HFpEf. The presence of a high pulmonary vascular resistance at the time of cath is associated with increased risk of all-cause mortality in patients with HFpEf. So we've been interested in what is causing pulmonary vascular disease and what is leading to abnormalities in these groups. We looked at patients with HFpEf, and we stratified them into patients without pulmonary hypertension, which is actually kind of hard to do with a high wedge pressure. Patients with isolated post-capillary pulmonary hypertension, so just left atrial hypertension, but no high pulmonary vascular resistance, and patients with what's called combined pre- and post-capillary pulmonary hypertension. So they have a high left atrial pressure and a high PVR. And we did the rest exercise hemodynamics, high-fidelity catheters, gas exchange. This is what we see. So cardiac output plotted on the y-axis versus exercise workload. Cardiac output is much lower at rest in patients with combined pre- and post-capillary pH. It increases much less to a lower absolute value, and the delta cardiac output is lower as well. Despite this, the pulmonary artery pressures increase to a much more dramatic magnitude relative to the amount of venous return coming back to the right heart. This then leads to acute right atrial hypertension, like I was showing you earlier. So the patients with combined pre- and post-capillary have the most dramatic increases in right atrial pressure as more blood is coming back to their right heart, because their right heart can't eject it through the lungs, because the lungs aren't compliant and because they're remodeled. So why is this important? I want to step back to basic physiology, because this is a really important point to talk about the concept of transmural pressure. So we think about preload of a ventricle, and you think about end diastolic pressure, but that's not really preload. What determines the Frank-Starling relationship, the avidity of interaction between the thick and thin filaments, is not pressure, but actually stretch. So preload is more accurately conceptualized as end diastolic volume. This is related to the transmural pressure. So what's the transmural pressure? That's the pressure from within that's distending the chamber. So those are the forces that are acting to fill the ventricle to a larger volume. But that's not the pressure that we measure with our pigtail catheter or balloon tip catheter in the chamber. The pressure we measure is equal to the sum of the transmural pressure and the external pressure applied to the heart. What's the external pressure applied to the heart? The pericardial pressure. It's not easy to measure pericardial pressure, but John Tyberg showed many years ago that you can very accurately estimate it by right atrial pressure. It's a strong surrogate for pericardial pressure. And you can therefore define LV transmural pressure as the difference between wedge pressure and external pressure or pericardial pressure or right atrial pressure. So when we look at these patients that develop marked right atrial hypertension because of right heart failure and pulmonary vascular disease, as compared to patients with isolated left heart disease where transmural pressure goes up as cardiac output goes up during exercise. The patients with pulmonary vascular disease and abnormal RV-PA coupling have a reduction in left heart filling and transmural pressure. So they have markedly inadequate cardiac output due to the right heart, but it's actually due to a problem in left heart, Frank-Starling reserve. They have an underfilled left heart. If you did a simultaneous echo, you'd see a D-shaped LV and the septum is pushing over. And it's a very different pathophysiology. You know, is it close to 8:30 right now? Is that clock correct? I think I should skip forward to the end so we allow enough time here. Are we, or, oh, it's 8, I'm sorry. I've got time. We got till 9.
We have till 9. Yes.
Okay. Senior moment. More coffee. I need more coffee. All right. All right. There's a minor panic for a moment there. I felt like I was going, I'm really taking a long time to go through these slides. All right. So that's the people with advanced pulmonary vascular disease, this combined pre and post-capillary pH. But we see that pulmonary vascular disease is not restricted to those patients. So these are patients with early stage HFpEf, like I've been showing you, like that first case, more exercise-induced pulmonary vascular disease. Their PVR at rest isn't really much different than normal controls, people with non-cardiac dyspnea, but their pulmonary vascular reserve with exercise is impaired. So normally your PVR should go down, flow-mediated dilation, enhanced endothelial function, vascular recruitment, but that is impaired or blunted in patients with HFpEf. And you might say, so what? You know, like their PVR is like 2, not a big deal. But in fact, their exercise PVR is a strong correlate and determinant of peak aerobic capacity. So you can see peak VO2 is much lower in patients with a high PVR. And it's also, again, even with these very minor elevations in PVR on exercise, it's a predictor of increased risk of hospitalization when you follow these patients out. So maybe it's a therapeutic target. So how could we treat that? Could we treat it? Well, we did a study a couple years ago where we gave dobutamine to people with HFpEf and controls. And we saw that PA pressure went down and PVR went down with dobutamine in HFpEf. Actually much more than it did in controls, which was very interesting. And the PA pressure flow relationship actually was much attenuated with dobutamine treatment. You can't give dobutamine chronically. I mean, you can, but you wouldn't for most outpatients with heart failure. But what could you give that's a beta agonist that would be very easy to give? Albuterol. Albuterol is a beta-2 agonist. Beta-2 is the mechanism by which pulmonary vascular tone is altered. So we asked the question, could acute therapy with albuterol improve pulmonary vascular reserve during exercise? And the reason we specifically chose exercise is because, again, it's the stress of exercise that brings out these dynamic abnormalities that are often not present at rest in patients with heart failure. So here's the study design. So we took patients with HFpEf undergoing evaluation. They had baseline hemodynamics, micromanometer catheters, exercise hemodynamics, submaximal exercise, 20 watts. That is submaximal for us. It's peak for some patients with HFpEf for 5 minutes, measure their hemodynamics, come back down to rebaseline. After this, they are then randomized to inhaled albuterol or inhaled normal saline, double-blind, placebo-controlled, and then repeat baseline hemodynamics, repeat exercise hemodynamics exactly as the first time. Primary endpoint was exercise PVR. This is a very robust design because of the fact that the patient has already done exercise. You eliminate a lot of variability between patients that's just related to kind of their own exercise signature and allows you to get answers with relatively small sample sizes. This is what we saw. So the primary endpoint, exercise pulmonary vascular resistance, no effect with placebo, but a 40% reduction in exercise PVR with inhaled albuterol. And it was very consistent across all the pulmonary vascular indices. Greater increase in PA compliance, greater reduction in PA elastance, PA pressure goes down, the PA pressure flow slope also decreases. And that's shown here. So these are PA pressure flow relationships. So as your cardiac output goes up during exercise, your PA pressure goes up, and people with heart failure have a steeper slope there. People that are healthy have a nice shallow slope because they can recruit more blood vessels and they have more vasodilation in their lungs. You can see that placebo had no effect on the pulmonary pressure flow relationship, but albuterol really attenuated or brought this down. And you can also see that at the same workload of 20 watts, the cardiac output is 20% higher after getting albuterol. So that pulmonary vasodilatation is really enhancing forward flow through the system, improving systemic blood flow, which we would expect to improve symptoms like fatigue and shortness of breath. I showed you the transmural pressure earlier, and the reason why I spent so much time on that is because it's not just restricted to these people with advanced disease. So people with severe right heart failure and RV dilation, septum is pushed over, their transmural pressure gets reduced. But even in these earlier patients, we saw that transmural pressure actually went up with albuterol, even though wedge pressure wasn't affected. And that's one of the concerns about using pulmonary vasodilators in people with HFpEf. Maybe you'll get left atrial hypertension, but we did not see that at all with albuterol. And in fact, the degree of change in transmural pressure was pretty well correlated with the effect of albuterol on PVR. So maybe unloading the vasculature can improve left heart filling, and maybe that also contributes to that increase in systemic cardiac output. We saw improvements in RV-PA coupling. Again, I showed you earlier that this was the strongest correlate of an increase in lung water during exercise. Albuterol substantially was improving the ratio of RV S prime to PA pressure or TAPC to PA pressure. So maybe, cheap low-tech drug might work. So we've talked about lots of victims, but the final victim of chronic elevation of left heart filling pressures is the right ventricle. And we've known this for a couple of years now. It's not just isolated left heart failure. When you have HFpEf, a lot of people develop RV dysfunction, and it's very bad. This is data where we looked at RV function relative to PA pressure, and when you account for PA pressure, you can see that there's a much stronger load dependence, so there's a greater diminution of RV fractional area change as pressure goes up in patients with HFpEf as compared to controls. And the presence of RV dysfunction, like a high DLCO, is a really strong indicator of increased risk of death in patients with heart failure and preserved ejection fraction. This has been just shown repeatedly since that time. So we have been interested in thinking, well, what really is the natural history of RV dysfunction? Who are these people that get this? Is it a different thing? Is it so, people talk in the literature about so-called RV isolated right heart failure, or maybe it's ARVC, or maybe it's, from sleep apnea. But, what is the implications with HFpEf with that? So we just published this paper earlier this year in European Heart Journal that looked at this. So tried to marshal together all the patients that we had accumulated in the cath lab. So on the one side, we looked at all patients that underwent coronary angiography, went through all of them, and took all patients that had hospitalization for HFpEf. So unequivocal HFpEf, admitted for pulmonary congestion, treated with diuretics. So that was one source that led to 179 patients. In parallel with that, we also looked at the invasive hemodynamic practice and looked at all the patients that had definite, true HFpEf identified by invasive catheterization, by the hemodynamics. And then we included 27 controls just sort of as a comparator group. So that's the patient population that we're looking at. And again, you can see pretty typical of HFpEf populations: older age, slight female predominance, obese, mean BMI 32, lots of comorbidities, diabetes in 30%, AFib in 40%, and coronary disease also quite common, 60% of patients. The hearts looked pretty typical for HFpEf, high E to E prime ratio, mildly reduced RV fractional area change, but not horrible, 48%. So the average is that there's not RV dysfunction here, and the RVSP was 44. So what we did was all the patients, I should have mentioned this earlier, all patients required to have 2 echocardiograms that separated by at least a year. So we looked at what happens between time point A and time point B in your LV function and RV structure and function. And over a median follow-up period of 4 years, there was no change in RV fractional area change, as you can see here in the controls. Over the same time span, there was a pretty substantial reduction in RV fractional area change. On the right-hand panel, you can see that the prevalence of RV dysfunction at the first echo exam in these patients was only 12%. But after 4 years, these patients that look like isolated left heart failure, the prevalence increases by 2.5-fold to 30%. So pretty striking. And this graphic, I think, really hammers the point home. So this is the longitudinal changes in LV size and LV function, estimated by ejection fraction. Pretty minimal. 3%, so your EF is going from 57 to 54 maybe. Really not much change in the left heart. In contrast, substantial increase in right heart size. These are retrospective echoes, Eric, so this is, looking at data retrospectively. It would have been much better with things like 3D echo and more focused views, but this is what we had available. Pretty substantial increases in RV size and a pretty substantial reduction in RV fractional area change. So chronically in patients with HFpEf, a disease that really we think of as isolated, pulmonary left heart diastolic dysfunction, changes in the right ventricle, both structural and functional, greatly exceed the changes that we see in the left ventricle. You may say, I don't, fractional area change, that's kind of old school, I don't like that, but we see the same exact thing when we look back and look at RV free wall strain. Significant reduction over 4 years' time in the same patient population. But it doesn't just affect the right ventricle. There's other chambers in the right heart. So this is the right atrial area. And you can see that in the controls, there was no significant change. In the patients with HFpEf, there was significant right atrial dilatation at rest, The prevalence of moderate or severe TR didn't change in the controls, increased from 20% to 30% over 4 years. Atrial fibrillation, very important part of this pathophysiology. So only 25% of the population was in persistent AFib at exam 1. 4 years later, that number had increased to 45%. So now I'm going to show you how the differences are in the people that developed new onset permanent AFib, persistent atrial fibrillation. So fractional area change, overall, again, reduction even in the people that didn't develop AFib, but in the people that did, twofold greater. Almost a 20% absolute or relative reduction in fractional area change. Right atrial area, twofold greater with AFib. Left atrial area, or left atrial volume, threefold greater increase. Prevalence of moderate or severe tricuspid regurgitation, 15 to 40%. So the development of AFib is a watershed moment in these patients. And yeah, you could say that part of the AFib is due to the right heart failure, but the AFib is directly causing that. And it's very important because AFib is treatable. We looked at the predictors of development of incident RV dysfunction, increased body weight. We've been very interested in this obesity-related HFpEf. That's an important part of this. Having AFib at baseline, big risk, and developing atrial fibrillation, also strong risk factor, all preventable. And then, of course, the last one here, having a higher wedge pressure. Having a higher wedge pressure, even more than things like PVR, was a really strong predictor of developing RV dysfunction 4 years later. That's really where it all starts. So this has been shown before that presence of RV dysfunction is a strong risk factor for all-cause mortality in patients with HFpEf. But what hadn't been shown before was looking at incident RV dysfunction. That's what we did here. So we took the patients who had normal RVs. They looked just like your plain isolated HFpEf at baseline with left heart disease. And the patients that went on to develop RV dysfunction over just 4 years, 90% increase in all-cause mortality, independent of other predictors that we look at. So this is really an important downstream effect that we see in this patient population. So in conclusion, hopefully I've convinced you that diastolic dysfunction is bad. And yes, this increase in LV filling pressures with exercise is a very bad thing. It leads to symptoms of breathlessness. It leads to increasing lung congestion, impairs exercise capacity, and it's associated with poorer survival. The increase in lung congestion is largely related to increased water filtration from the capillary space into the interstitium due to left atrial hypertension, but we think there's also an important role for right atrial hypertension and RV dysfunction, and all of these things chronically cause lung remodeling that affects the alveolar capillary interface, but also affects the vascular resistant properties and capacitance properties of the lungs. Ultimately, this leads to pulmonary hypertension, pulmonary vascular disease, which then causes RV remodeling, RV dysfunction, atrial remodeling, tricuspid regurgitation, and that end stage of heart failure with preserved ejection fraction, where we see very bad outcomes. Further study is needed to determine how best to reduce LV filling pressures more effectively, and there's lots of things that are being tested, and we can talk about that if we've got some time now. But also to treat and prevent the upstream causes of high filling pressure. So what are the things that cause LV diastolic dysfunction in the first place to increase LV and diastolic pressure and left atrial pressure? In parallel with that, we need better ways to treat and prevent the downstream sequela, the effects on the lungs, lung vasculature, lung parenchyma, and right heart. And hopefully with that, we'll be able to make some progress in this disease. So with that, a hearty thank you. That's my house. We had, last week, we had the highest snowfall ever in Minnesota in February, and that's my son up there at the top of the mountain. So thank you. Thank you very much.
That was a great talk.
Thank you.
The question is whether we need to revisit some of the things that we've abandoned in cardiology.
Ah, yeah.
So one is thallium stress testing, where we look at lung uptake. Lung uptake is related to pulmonary capillary wedge pressure. So we don't do that any commonly anymore. The other is with the tech labeled agents, we used to do exercise, RV and LV function and volumes during exercise. And I think it's easy to accomplish with, in combination with perfusion. I think with a growing population of HFpEf, I think we need to go back and assess RV function and volumes during exercise.
I couldn't agree more. And I don't know if you know Todd Miller where I work, but I've talked to Todd for years, and he keeps like, we can't get those old the gamma cameras anymore. They don't even make them, you know, we can get on eBay or something. But I've been wanting to do this for years because exactly what you say, it's exactly right. We did look at lung uptake a couple of years ago, back in 2006, and we didn't see as much differences. It's complicated because you've got an increase from the congestion, but then maybe a little bit of a decrease from that oligemia, that inability to increase. So it's complicated, but I think it's ripe for future study. And again, it's old technology, as you point out. Couldn't agree more.
Wonderful, wonderful talk. I'm intrigued by the pulmonary vascular remodeling. Wondering if there are some common mechanistic features with pulmonary arterial hypertension, for example. So are the mechanisms known? Is this a smooth muscle cell proliferative phenomenon? And what's the trigger? Because that could be a target for intervention.
That's true.
Especially as it relates to the right heart alterations that you described are so important.
It's a great point. I mean, I will say, I'll couch this and say that, you know, that it's like one study basically. You know, there's another study from Europe, but it doesn't look like there's a lot of vascular smooth muscle thickening. There's not the plexiform lesions and stuff like that with PAH. It's more intimal thickening. It's more in the smaller vessels and the veins. So histopathologically, it looks a bit different than what we think about with pulmonary arterial disease. But people are still pursuing treatment with pulmonary arterial vasodilators for HFpEf. There's a study called Southpaw of the prostanoid. There's Serenade, which is an endothelin antagonist. So there's a lot of interest in this. We had the albuterol thing. So it's still an important target, I think.
Excellent talk, and I have one question related to what Jeff actually asked, and that is actually what the DLCO that you said it changed was very intriguing, and I was actually surprised that among your predictive risk factors for was not a pulmonary disease such as pulmonary fibrosis, COPD, etc. And then when the DLCO actually changes, we see retention of CO2 in our patients in the primary pulmonary disease. Do you observe that in your patient? That is, CO2 changes because the gas exchanges changes.
That's a good question. Not that I recall having seen, but I'm not sure that I've specifically looked at that. We're starting to look at gas exchange in a more sophisticated way now. We've got a mass spec cart, big cath lab, so we can measure DLCO and DLNO to measure membrane conductance in the cath lab. So we're doing it at the time with our molars in to really get to that. And then we're doing simultaneous blood gases, arterial, mixed venous, and wedge. So I think we'll be able to get to it. It's a great comment.
So Barry, brilliant talk. Really enjoyed it. As you were talking, especially really throughout, it sort of was making me think that a lot of these LV therapies that we think of as, oh, this never works in HFpEf, like milrinone sounds like a brilliant HFpEf drug,
Yeah.
RV inotrope and a pulmonary vasodilator. And I mean, has anyone ever talked about taking like really bad HFpEf and recovering them with an LVAD? I mean, the best way in the world to keep the LA pressure down for a while is put an LVAD in for 6 months, remodel the lungs, and take it out.
Not to my knowledge. The suck down, wouldn't you worry about the suck down of a small non-remodeled ventricle? But milrinone, David Kay has an oral milrinone that he's got the license for, and he's tested that, and it improves exercise hemodynamics. It was a research letter in JACC, and he's pursuing that with a larger scale trial now. Part of the things with albuterol in addition to pulmonary vascular might have a little bit of an inotropic effect. And then there's an ongoing study right now of levosimendan, which is a calcium sensitizer, KATP channel active drug. It's like milrinone, so it's an inotrope, sort of an inodilator. It's used in Europe, didn't get approved here when we were in the big inotrope phobia period where inotropes kill. Of course, now we're thinking like, well, maybe that's not such a bad thing. It's better to have quality of life, and but that's being tested. Levosimendan is being tested in patients with PH-HFpEf for all of those reasons. And even if they get VT in an EF of 55%, it's probably going to be okay. We're participating in that trial. The first patient has been done, and as part of it, they have to be a responder. So they have to have a favorable response to levosimendan, and then they get randomized if they do. The first lady had just this dramatic response. So her cardiac output went from like 3 to 4. Her RA pressure and her wedge pressure went from like 25 and 40 down to like 12 and 25. So we'll see. I mean, a lot of the things that we used to think were verboten maybe are good treatments for these people.
I have a question related to what you said about persistent atrial fibrillation as a predictor. And then you said, and this is a treatable thing, implying that it's actually in the causal pathway. But so my question is, are there actually data suggesting it is in the causal pathway as opposed to just a marker for worse disease? Is there any data that you are aware of that treating it will improve HFpEf? And if not, are there any plans to get that data?
There is acute data with tissue Doppler function that shows that RV function improves acutely with cardioversion. So that's mechanistic data. And then our data, I think that people that had no history of AFib, but the developing incident AFib was associated with developing RV dysfunction. I think that our data supports the causal pathway that you mentioned. There's not a good rate versus rhythm control study in HFpEf. We've done it. We've kind of been there in HFrEF. Cabana, I've been talking to Doug Packer to get him to do an ancillary. So hopefully we're going to learn something from that, because I'm sure a lot of those people in Cabana had occult HFpEf. If you want to find HFpEf, it's in EP clinic because of the strong interactions with atrial fibrillation.
Very wonderful talk. I mean, maybe a comment and then a question. Comment is, listening to you speak and kind of recognizing the arc over the last 13 years is really remarkable, and kind of congratulations to you. I mean, for those who don't know, Barry was in David Cass's lab, and then actually was one of the first Heart Failure Network fellows. So perhaps the only thing we did really good in the network was to create people like you and Greg Lewis and Tarek and others from the network over its last 10 years. So congratulations. The question is, one of the challenges to moving forward this field is the relative lack or insufficiency of animal model systems for HFpEf. And you really have shown, a real bedside to bench kind of potential here. And, could you kind of give us some thoughts on what you would imagine now that you know what you know about how you develop an acute and then chronic HFpEf animal model, and what are the features that you would want to impose on that to kind of study? Because, being in study section, it's remarkable how bad the recommendations have been around how to study this.
Yeah, it's one of the hugest barriers, Eric. It's a great point. And I would say an animal model that develops from the same risk factor profile, so metabolic stress, hypertension, obesity, and then that recapitulates as many of the pathophysiologic sequela as it can. You know, left atrial hypertension, normal EF, pulmonary vascular disease, eventual RV failure, poor exercise capacity, wet lungs. As a matter of fact, Joe Hill just published a paper, I don't know if you saw it, in Nature, and they did just that. It was a pretty simple model, actually. It's like L-name and obesity, I think, metabolic stress. And they had all of those things. They had a normal EF, they had increase in lung weight, they had poor exercise capacity, they had abnormal hemodynamics. So maybe, and it's a murine model, so it's, you know, pretty easy to do in large numbers. I think there's others. I think large animals, you know, are a little bit closer to humans. A lot of times things that we identify in mice don't work for people, and I think that especially might be true in HFpEf. There's pig models where you overfeed and induce hypertension, either with inducing renal artery stenosis. And we've used a model like that. They get coronary endothelial dysfunction, high filling pressures, a lot of the various phenomena. You know, pigs are much more expensive, and it's hard to do different. So I think those kinds of models are probably going to be the best.
So you may, and then
wonderful talk. So there are heart failure with preserved ejection fraction and heart failure with failed ejection fraction. So what determines a heart failure to be HFpEf versus heart failure with failed ejection fraction at a kind of mechanistic insights?
Well, the short answer is we don't really know. I think that there are two different diseases. This was argued for years, and I've actually been involved in this argument, like, you know, in a paper, like, I think in like 2011 or something like that. But I think the most evidence suggests that, I mean, they're both heart failure in that they have high filling pressures and lead to congestion and stuff, but I think they're totally different diseases. I think in HFrEF, you have more an original severe myocyte dysfunction, whether it's ischemic or myocarditis or some sort of genetic problem that's either known or occult, and that causes ventricular remodeling, dilatation, and dysfunction. HFpEf is different. You know, it's related to obesity and aging and hypertensive stress. The ventricles don't get big, at least the left ventricle. Might get a little bit hypertrophied, but the chamber doesn't dilate. So I think that they're just two different diseases, but, you know, they look the same to the lungs, and they look the same to the right heart too, you know. That's why there's similarities and differences. And the studies that have looked at like different biomarker profiles and things like that, things like cardiac injury with like highly sensitive troponin is a much stronger risk marker for HFrEF. Higher BNP is more of a marker for HFrEF. Things like albuminuria is more of a risk factor for HFpEf. So, but that I think is just related to those underlying risk markers, which are related to two different diseases.
last question.
Great talk. My question just relates, you started off your presentation with the difficulty in diagnosing it sometimes. Can you comment on the use of stress echo, perhaps some non-invasive modalities in diagnosing it? I know there's data looking at E and E prime, but what about TAXI and tissue Doppler?
Yeah, I think, so we looked at that. We did a simultaneous echo cath study, and we did see when you rigorously apply like the ASE criteria for diastolic dysfunction, it didn't really help at all. When you just look at EE prime, if you had good Doppler spectra, there was an incremental value. There was an improvement in sensitivity, but a little bit of a compromise in specificity. We didn't try to incorporate looking at like dynamic TAPSE and stuff like that. That hasn't been done yet, to my knowledge. So it looked good in our study, very carefully controlled environment. But then when I looked at our series of clinical cases and just sort of applied the same algorithm using the exercise EE prime, it wasn't nearly as good. And it worked in our group, in our hands, but a number of other studies have shown that exercise echo isn't that robust. So it's kind of, I think, to be determined. I think we need like simultaneous assessments, multi-center studies, and then think about the best markers. You suggest like TAPSE and stuff. There's probably like you can do too much. If you do too much, then you won't get anything. If you really focus on getting a couple things, then maybe you'll do it well. We need more data.
So we haven't talked about diuretic therapy at all.
Yeah.
This is an interesting condition.
Yeah, well, I've only got so much time here. There's much more I could have talked about, but no, that is really where we're at with HFpEf. I mean, if you ask me like, how do we treat it? diuretics. If they're congested, if they have high filling pressures, diuretics. That's what all that data, I mean, a lot of the things, a lot of those chronic effects on the lungs, and ultimately the right heart would get better theoretically if you just diurese the patient more and not have them walk around with a wedge pressure of 20 or 22.
Yeah, pay you for that.
No, I think people with HFpEf are vastly under-diuresed. And given the TopCat results, which is kind of positive, I'm frequently using spironolactone in these people along with a loop diuretic.
Barry, I'm going to put you on the spot. Knowing everything that you know about HFpEf, what do you think will be the result of Paragon with Entresto and
oh, jeez. Scott knows what he's doing. I think it'll probably make it. I think that, but we'll see. I mean, we've thought that many times, haven't we, with HFpEf, and a bunch of offers so far. So we'll see. SGLT2 inhibitors maybe as well. We'll find out in a couple of years.
Yes, you elegantly demonstrated that part of HFpEf may be a cardiopulmonary syndrome.
Mm-hmm.
That there is a significant involvement on the right side. How would you clinically, or even in the laboratory, distinguish that from the old core pulmonary? They're all obese, they all have lung disease, they're older.
Well, ultimately with, invasive measurements, I guess, to see that there is left heart failure. Without that, if you've got good non-invasive surrogates for that, I guess that would be supportive. If you don't, then you're kind of stuck. You don't know if it's core pulmonary or if it's HFpEf related.
So is it spectrum? I understand that you may be in the cath lab demonstrate element in that paper practice in your clinical side where you see someone with quote unquote right heart volume retention or right heart failure. Half of them may be core pulmonary.
Right, but since you could, if our diuretics will work to treat that, then you want to identify those people with, heart failure related core pulmonary and treat them aggressively. So then I would say that you should take them to the cath lab.
The answer was always take them to the cath lab.
By the way, yeah.
I wanted to have a word in the last question.
Diastolic heart failure or a diastolic low filling. You have a paper that comes out in the late 80s about the hypertensive aspects of the elderly of diastolic dysfunction. Then now you just stated that's finding. Then we say that diuretics is an appropriate treatment for both. If you just look at the Frank Starling curve and said you had high filling pressures, right? If you gave these preload, then you might get into a worse situation. You get failure. Frank Starling curve with a failing heart has the same issue. So my question is just that there are some crossover patients with HFpEf who have LV dysfunction. Why can't it be spectrum with some special cohort instead of saying that it's a binary distinction?
Well, yeah. I mean, there are people that had HFpEf that develop HFrEF. And there are the people that have more coronary disease. That's the best indicator of those people, even if they don't have a clear MI event. Part of this so-called descending limb is related to that pericardial restraint. When the right heart gets really overloaded, that's like sort of uncoupling the relationship between pressure and volume. But I hear what you're saying. I think that, with more rigorous methods to phenotype these patients, maybe we'll make more progress, because having this binary thinking, it's this or this, that's oversimplifying a very complex system.
It's just that, there are distinctions that are made that are not helpful sometimes, and we should have another way of looking at it, because it would alert us to the fact that all patients may have some underlying commonality. And I do believe there are distinctions.
Mm-hmm.
I do believe there are distinctions. But it's as someone who's an educator who's thought about this, sometimes it's more coherent to say that we don't know, but we certainly see some people cross over.
Mm-hmm.
And when the recent RV had a peripheral arterial disease, right?
Mm-hmm.
So that means that there's a homeostatic response. We have an increase in people vascular resistance at the same time, right? You have a high filling pressure, so that may say something about the patient's response to different primary insults that have been yet recovered, and they respond to it.
I agree. I think we need better phenotyping, and it's more than 2 things or 3 things, but we don't want to make it too much because it's lumping versus splitting. If you split too much, you come out with nothing. But I think that having HFpEf, it gets you in the door, and then you should have some sort of HFpEf clinic, which is then able to open it up again to be more sophisticated. You're this kind. You're kind of an LV disease. Maybe you're going to become HFrEF. You're this other phenotype, but you've got to get in first with the HFpEf.
If you exercise patients with stress tests, and they have an increase in progression, they have a high mortality, right?
Yeah,
so that's a response that's, abnormal. What Fried said, I think it's when you have high filling pressures, you start getting ventricular interaction. You might not have poor pulmonality as defined by RV dysfunction.
Yep.
Barry, thank you very much.
You bet. Thank you.